Everyone. I'm Dr. John Shrigley, the clinical lead for the CCO Pathology Project and the chair of the National Pathology Standards Committee for CPAC. On behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome everyone to today's educational session on the checklist on testis cancer with Dr. Yilmaz from Calgary. Before I introduce our speaker and we get underway formally, I'd like to take a few housekeeping items. Today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time to be followed by up to 30 minutes of questions and answers. This is being recorded and will be made available to all participants via email links once the recording becomes available. Live presentation and the recorded presentation are eligible for CME credits upon the completion and submission of the evaluation form available electronically. The information for accessing the evaluation form was provided in the notice for the session previously distributed. Note that the CME certificates for each of the CAP checklist sessions will only be issued for 1 month from the presentation date. The recorded sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. Due to a large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you're having difficulties accessing the WebEx portion of the teleconference, please call the WebEx support line at 1-866-229-3239. We encourage you to submit questions at any time during the presentation using the chat feature. For information on how to use the WebEx chat window, please refer to the documentation that has been previously distributed. During the question and answer portion of the presentation, in order to avoid question collisions, I pose the submitted questions on your behalf as long as time permits and in the order in which they appear. In the window, please indicate the following information: your institutional name, the name of the person posing the question, and finally, your question. It is your pleasure to introduce Dr. Yilmaz. Dr. Yilmaz completed her residency training in anatomical pathology and a surgical pathology fellowship at Ohio State University. She completed a year of oncological pathology at Memorial Sloan Kettering in New York, and additional training there in genitourinary pathology with Dr. Victor Reuter. She joined the University of Calgary Department of Path and Lab Medicine and Calgary Laboratory Services in 2001. Currently, Dr. Yilmaz is an associate professor with the Department of Pathology and Lab Medicine, University of Calgary. Her expertise and research interests include urological pathology and predominantly testicular cancers. Anatomical pathology at Rocky View General Hospital is part of a centralized regional urology program in Calgary and is one of the largest uropathology centers in Canada. Dr. Yilmaz serves as a uropathology specialist consultant for Southern Alberta and for the Tom Baker Cancer Center in Calgary. I'll give you your phone now.
John, it's a pleasure to be a part of this educational series. Today's focus is going to be testicular cancer. I hope you'll find this and all the audience useful, and hopefully the next orchiectomy specimen that you need to handle will be a piece of cake. This is a presentation. I wanted to start with a happy picture, another happy day with our staff, full staff at Anatomical Pathology. This is me, so that you can put a face on my voice and guess where my accent is from. Objectives of the next hour is going to review of CAP-approved checklist for testicular cancer. The date on this one, October 2009. We'll discuss the checklist elements, which are mainly based on AJCC 7th edition of TNM classification. The goal actually is to make the presentation relevant for routine practice, which will basically include approach and handling growth and microscopic examination of radical orchiectomy for testicular cancer. And I'd also like to discuss selected diagnostic challenges and common pitfalls on diagnosis of testicular cancer. This is uncommon, but I think what makes it challenging is the fact that most pathologists will only deal with a few in a year. And although a small organ, it encounters tumors with complex histopathology. The goal applies to malignant tumors of testis, and since more than 95% of the malignant testicular tumors are germ cell tumors, will be the main focus of today's presentation. I would like to go through some facts and introduction on testicular germ cell tumors, since this is going to be the main focus of today's presentation. Again, more than 95% of testicular tumors are germ cell tumors. And I want to stress the fact that it's the most common malignancy in young men, and it's the most common solid tumor at the age group of 15 and 45. Why is it important? It's important to stress the fact that any specimen that's coming as a biopsy or a metastatic site from a young male, the testicular cancer should be in the list of in your differential diagnostic list. Although it's uncommon cancer, its incidence is increased in North America and Europe, and there's a higher incidence in Central Europe. The cause is known, but there's a very common DNA abnormality that's associated with all germ cell tumors, which is an isochromosome of the short arm chromosome 12, which is found in all germ cell tumors. The unique feature of testicular germ cell tumor, it's been a model for a curable cancer after the introduction of cisplatin-based chemotherapy. This is of Lance Armstrong, famous athlete, which was diagnosed with an advanced stage metastatic testicular cancer at the age of 25 with brain and lung metastasis. He not only survived the cancer, but also he has won 7 consecutive Tour de France. It's to know that clinical stage is critical for management of testicular cancer, since advanced stage presenting patients receive some sort of adjuvant therapy after orchiectomy, which is not an issue in terms of management. But since the majority of the patients presents at stage 1 disease, which is confined to the disease, will be cured by orchiectomy alone. So the question right now to answer for the clinicians is to predict who is going to relapse, who's going to progress. The data from the orchiectomy specimen is very crucial to identify these patients who are at a higher risk of relapse. This is the base of my talk, which is the current TNM classification for testicular tumors. Basically, PT1 is for tumors which are confined to the testis. PT2 is tumors which has vascular invasion or tumor invasion into the tunica vaginalis. PT3 is when the tumor spreads into the spermatic cord. PT4 for tumors where tumor invades into the scrotum. Majority of the checklist presentations also covered the changes that are present in the current edition of the TNM classification, which will be pretty straightforward for today's talk, since there has been no change since 7th edition of AJCC for testicular cancer. The only GU cancer that the classification for staging stayed similar. This is going to be the outline of the presentation. Serum markers and specimen laterality is related to the clinical information that we receive, and we'll discuss about the relevance of that. So tumor focality, tumor size, and macroscopic extent of the tumor is information you gather from the gross examination of the tumor. The histological subtyping, microscopic extent, presence of vascular invasion and margins is something we gather under the microscope. And then we sum all the data to put an accurate PT staging on the orchiectomy specimen. The relevance of serum tumor markers, because it is part of the CAP checklist for testicular tumors. As a pathologist, you all know in our practice, we're lucky if we actually receive the laterality of the tumor of the orchiectomy specimen specimen when we receive it. So it's very common that we'll receive a requisition sheet which says the information on serum tumor markers. But the relevance of knowing the serum tumor markers, even if you don't report it, which we don't do report it as part of our pathological reporting, because they can help us to subtype the histological subtyping of the testicular germ cell tumor. It may be in normal limits, but if you have an increased alpha-fetoprotein, you have to think about yolk sac presence in the tumor. Beta-HCG elevation, especially significant amounts of it, is always associated with presence of choriocarcinoma. LD elevation is usually more associated with seminoma. So we're working on an orchiectomy specimen. It will be helpful for you to know the serum markers, and it also guides clinician on patient management. So growth examination is always a very crucial step in any oncological specimen. The specimen is easy for testicular cancer because it's always radical orchiectomy. Partial resections, biopsies is not a common practice on testicular cancers. Anatomy specimen, radical orchiectomy specimen, is composed of testis, epididymis, a segment of spermatic cord, and associated tunics. Should be received fresh, ideally, and tumor sampling should be done after adequate fixation, usually overnight. You see, testicular tunic is a quite thick fibrous that do not permit penetration of fixative, so which could be a major source of diagnostic problems if urologist sends the specimen intact and formalin without bivalving, which cause some autolytic changes in the tumor. So after recording measurement and weight, a careful examination of the tunica vaginalis, the testis should be opened much like a book in the plain long axis through the testicular hilum by using a long sharp knife. Think steroid is poor fixation against stress, tumor contamination to the margins, and undersampling of the tumor and tumor extent. Some anatomical landmarks, more straightforward. This is the schematic presentation of testis, and it shows how the parenchyma is very lobulated by fibrous septate, which are composed of complex seminiferous tubules that irritates to the testicular hilum and forms reeded testis, which joins into the epididymis, which sits on top of the testis and follows with mid-portion, tail, and then joins into ductus deferens. And again, pay attention that it's covered by a layer of tunica vaginalis, which is basically not present in the testicular mediastinum or hilum. So sample a radical orchiectomy. It's easier to show it on a real, probably specimen after bivalving and again fixing overnight. Sections should include spermatic cord margin, distal, mid, and proximal. Again, histological parameters of the primary tumor is very important to put the patient on higher risk for metastatic disease. So the general sampling of the tumor is crucial. The sections should also include testiculum, tunica vaginalis, and tumor, epididymis, and also non-neoplastic testis. So when you're doing an orchiectomy specimen, this question should be in your mind. Am I dealing with a seminoma or a non-seminomatous germ cell tumor? Because that's the basis of the clinical management. So generous tumor sampling is important. Again, the question comes, how much sampling is generous or enough? Small tumors should be sampled in total if it requires less than 10 blocks to be practical. And tumors, again, at least 10 blocks, and usually 1 centimeter per each centimeter is adequate. Seminoma usually requires more general sampling, and generally speaking, you should be able to say the histological type of the tumor. Is it seminoma or non-seminomatous germ cell tumor by examination, gross examination. Usually seminomas will have a light tan color, fleshy, encephaloid type appearance on cut surface, and more heterogeneous appearance will be a typical presentation of non-seminomatous germ cell tumors. Why seminomas requires more general sampling? Even the tumor looks like a pure seminoma on gross examination. A microscopic presence of a smooth muscle component or any other microscopic presence of a non-seminomatous component will put diagnosis as a non-seminomatous germ cell tumor, and it could be microscopic, not obvious from the examination. So what are the parameters that we can gather for the CAP checklist by just gross examination? Tumor size, which recorded by the greatest dimension of the tumor mass. And if there are additional tumor nodules, again, they should be recorded as a separate line. And you should be able to assess local extent of tumor by, actually at least from the macroscopic examination. Is the tumor confined to the testis? Is there extension into hilar area? Is there any tunica vaginalis involvement? What's the status of epididymis and spermatic cord? Before getting into the histology of examination under the microscope, I would like to spend a few slides on precursor of testicular germ cell tumors, which has been originally noted by Dr. Skabebek as carcinoma in situ in 1897. The preferred term is intratubular germ cell neoplasia, unspecified type, which is usually stated as abbreviated as ITGNU. It's the precursor cell for all post-pubertal malignant germ cell tumors. They usually set these cells are malignant cells that are present against the tubular membrane, and they have very strong morphologic similarity with seminoma cells. They are cells with clear cytoplasm. Nuclei usually contains large nucleoli and irregular nuclear membranes. Later, it was recognized that if cells are left out, 90% will progress into germ cell tumors in about 7 years. This slide is based on the most recent model on histogenesis of germ cell tumors by Dr. Shrigley and co-workers. Again, note where the malignant transformation starts. A benign germ cell transfers into a malignant intratubular germ cell neoplasia, which turns into a seminoma, again, which sits in the center of a transformation of all other non-seminomatous germ cell tumors. Again, please note that with the exception of pediatric germ cell tumors and a few benign teratomatous entities like epidermoid cyst, dermoid cyst, and a unique tumor that's called spermatocytic seminoma, all other germ cell tumors are associated with this malignant precursor cell intratubular germ cell neoplasia. Again, you have an invasive tumor. What's the practical relevance of dealing with an in situ tumor in an orchiectomy specimen? It's part of a CAP checklist element, so it's something that you have to record. However, its practical significance that I've listed a few entities that usually helps me. If you're dealing with a tumor that looks a bit unusual, your differential will be, am I dealing with a germ cell tumor, or this could be a non-germ cell tumor malignancy? Finding that in situ component adjacent to the tumor is quite helpful. It's a step that you can do without even ordering immunostains. Again, since it's associated with malignant counterparts of germ cell tumors, when your differential diagnosis is, am I dealing with a benign or a malignant germ cell tumor? Again, dermoid cyst is an example of that. Is this a dermoid cyst or a pure teratoma? Again, go look at the periphery of the tumor to assess the presence of intratubular germ cell neoplasia. Another entity which we're going to discuss that is present as entity in germ cell tumors, burnt out, regressed germ cell tumors. When you're dealing with a scar in testis, is this a non-neoplastic scar or is this a regressed germ cell tumor? Again, the answer could be just finding intratubular germ cell neoplasia at the adjacent period of the tumor or lesion, and it's crucial to look for intertubular germ cell neoplasia on biopsies done for infertility because it increases the risk of patient for getting a germ cell tumor in 5 years, and they should be dealt with. So going to the histology, germ cell tumors, histological subtyping of germ cell tumors, the main question that you need to answer is this seminoma or is the non-seminomatous germ cell tumor? So any tumor that's not a pure seminoma is non-seminomatous germ cell tumor. Seminomas are the most common germ cell tumors, so let's start with discussing seminomas. And it's approximately 50% of all germ cell tumors. Mean age is approximately 40 years. Again, there is a relevance to checking serum markers before you deal with the orchiectomy specimen. Generally speaking, pure seminoma cases should not have any increase in serum alpha-fetoprotein or beta-HCG. So if you receive an orchiectomy specimen with elevation of alpha-fetoprotein, it means that you have to go back and sample the tumor. There must be a small component of Yolk Sac Tumor. And cure rate is high, like most of the germ cell tumors that are confined to the testis. It's approximately 95%. One thing to remember about seminomas, it's the only germ cell tumor that's very sensitive to radiation. So if you encounter a seminoma, that patient is treated by radiation therapy, that pathology should be reviewed. Correct diagnosis, again, is crucial in seminomas to avoid ineffective and overtreatment by chemotherapy. As a pathologist, what's relevant to report on seminomas, and it's important for diagnosis of patients, prognosis of patients. Management depends mostly on the clinical stage at presentation. So if the patient advanced stage, there will be an adjuvant therapy, So parameters of orchiectomy specimen is very critical in the management of stage 1 patients. So what's relapse in clinical stage 1 patients with seminoma? Retatestis invasion and tumor size has been reported to be associated with higher risk of relapse on these patients. Again, I should like to draw your attention to the fact that both parameters are part of the current TNM staging. So it also tells us that there is a gap between the CAP checklist and TNM requirements in testicular cancers, which may be revised in the next year if we have enough data. So how does a seminoma look under the microscope? Usually diagnosis of seminoma is quite straightforward. Sheets or lobules of clear cells, usually associated with fibrous septate that has some lymphoplasmacytic inflammation. Cells have clear cytoplasm, well-defined borders, nuclei completely round, square edges with more prominent or 2 prominent nucleoli. Gram-positive reaction can be seen up to 50% with scattered small epithelial cells, and usually it's a focal finding. How it can be extensive and can efface the entire neoplasm, which may be misdiagnosed as gram-positive orchitis. Presence of, again, precursor in situ component at the periphery of the tumor would be very useful in a case like this, or using immunostains for identifying residual seminoma cells. And this that's associated with not those germ cell tumors. However, seminomas can show significant amount of necrosis, which can be part of even growth. Sort of not an uncommon feature, I would say, is some seminomas, 10 to 15%, are associated with the presence of syncytoblasts. Syncytoblasts are these multinucleated giant cells that biomimos will be associated with positivity of beta-HCG, and even in serum, there could be an elevated, usually at hundreds, elevation of beta-HCG. Does it have any relevance? It could be diagnosed as carcinoma. However, presence of syncytial trophoblast does not make a seminoma a non-seminomatous tumor, or does not have any relevance to prognosis. Usually focal finding, and usually not associated with necrosis, and it's important to know that it could be associated with low levels of beta-HCG. Let's go through some unusual cases of seminoma. Why is it important? Because they could be diagnosed as non-seminomatous germ cell tumors if you're not familiar with these type of morphology, seeing these morphology in seminoma cases. There's a really nice paper from Dr. Albright which covers these unusual patterns of seminoma. And the one on the left-hand core is sort of a jigsaw type of pattern. And again, similar type of seminoma cells when you pay attention to cytomorphology and association with lymphocytes are there. These unusual morphologies can be focal or can be pure in certain tumors. Again, the one on the right, upper right corner is a plasmacytoid type seminoma where you don't see clear cells anymore. The cells are more eccentrically located. Again, may not look your typical type of seminoma. This is more unusual one where you see a microcystic type of morphology and can imitate a Yolk Sac tumor. This one on the right bottom is a more tubulo-papillary type morphology in a seminoma. And a differential diagnosis could be Yolk Sac or non-seminomatous germ cell tumor, or even Sertoli cell tumor. Cells can show significant atypia, where a lot of pleomorphic cells, more increased amount of mitosis, eosinophilic cytoplasm. They behave different. No, the subcategory of anaplastic seminoma is no longer is in use because there is no data to support that they do behave any different than normal seminomas. The importance is to pay attention not to diagnose them as embryonal carcinoma. Again, paying attention to architecture and the fibrous septa association with lymphocytes would be helpful, and immunos again are helpful on cases like this. I would like to stress three issues that may cause atypical appearance in seminoma. One is poor fixation. Again, if the tumor starts to get autolytic process, seminoma can look more atypical than normal. And as of granulomatous inflammation can cause some atypia. And again, in cases of seminoma, areas of transformation into non-seminomatous germ cell tumors, again, can look more atypical, and it should be addressed by appropriate immunostains because you can have focal areas of non-seminomatous germ cell transformation. Sneaky pattern of seminoma that I would like to briefly talk. Because all you can see is nests of our single cells that are present between the tubules of seminiferous tubules. It could be a focal pattern or it could be an exclusive pattern, and which may be associated with any mass lesion at all. Presence of seminoma can be missed on these cases. Seminoma cells are associated with inflammatory reaction. These cases can be misdiagnosed as even chronic orchitis. And again, all you can see can be a single or nests of atypical cells between the seminiferous tubules. In a study shown on this, said partial or complete presence of this pattern could be up to 30% of seminomas, and it may not be associated with grossly visible tumor. What makes difference is the calculation of tumor size. You have to pay attention if it sometimes involves the entire testis with this pattern, and it's usually associated with more poor prognostic parameters. are quite helpful in a case like this, where you can see KIT positivity, which is a positive immuno stain for seminoma that highlights all intertubular germ cell neoplasia and cells between the tubules in the form of nests and single cells. A unique tumor that's most commonly seen in elderly population is spermatocytic seminoma. It has unique features, but one thing I would like to remind on this tumor, it's rare. You'll never see one. It's present only in males, only in testes, looks atypical, but in a benign fashion. And about this tumor entity, spermatocytic seminoma, it could look very similar to a seminoma, especially the plasmacytoid appearing seminoma. The difference is there are three cell types in spermatocytic seminoma: small, intermediate, and large. And this seminoma has more different morphological features. Seminoma is associated with small lymphocytic component, which is not present in spermatocytic seminoma. And again, the major difference is intertubular germ cell neoplasia is present in seminoma, but not present in spermatocytic seminoma. It is time to shift gears because we're switching to the important subcategory of histological typing on germ cell tumors, which is the non-seminomatous germ cell tumors. Seminomatous germ cell tumors are all the tumors that are not pure seminoma. So that's not pure seminoma is in germ cell tumor category is seminomatous germ cell tumor. And we'll have one of those categories of tumors, either an embryonal carcinoma, teratoma, Yolk Sac Tumor, or Choriocarcinoma. The mixed component, meaning having more than one tumor type, is more common, is approximately 40% of all non-seminomatous germ cell tumors. Pure forms, there is approximately 10%, which means it could be pure embryonal carcinoma, pure teratoma, pure Yolk Sac Tumor, or pure Choriocarcinoma. Some important relative prognostic parameters on management of non-seminomatous germ cell tumors. Again, same thing. Clinical stage at presentation is very critical. Patients who presents with advanced stage will receive an adjuvant type of therapy after post-orchiectomy. However, majority of the patients, approximately 70%, will present as a clinical stage 1 patient. And it's very critical to assess histopathology on these patients to prevent relapse so that the appropriate management is given to high-risk patients. In non-seminomatous germ cell tumors, again, different from seminoma, the presence of large proportion of embryonal carcinoma and presence of lymphovascular invasion is associated with high risk of relapse in clinical stage 1 patients. Size and retestis invasion does not seem to be as significant in non-seminomatous germ cell tumors compared to seminomas. So parameters will place the patient into low risk, intermediate risk, or high risk for metastasis. Carcinoma looks under the microscope. Again, it could look solid, it could look glandular, papillary, or sort of a Yolk sac-like complex glandular cribriform appearance. So it have variable histological appearances under the microscope. Tumors are large, epithelioid, they have pleomorphic nuclei, coarse chromatin, and nuclei usually overlap. Necrosis is common. The cell borders are usually ill-defined with a large irregular nuclei and nucleoli. The significance of us trying to find embryonal carcinoma under the microscope, a First of all, it's the most common component of non-seminomatous germ cell tumors. And stage 1 patients, again, have risk of relapse if the tumor has a predominant embryonal carcinoma component. For a pathologist, it's important to record the percentage of embryonal carcinoma present in the orchiectomy specimen. Approximately two-thirds of patients with a predominant embryonal carcinoma will present with advanced disease. And again, presence of vascular invasion is usually more commonly seen in embryonal carcinoma, and which is a parameter of upstaging tumor on TNM. It's usually a component of mixed germ cell tumor. It's more unusual to see Yolk Sac tumor as a pure component, associated with an increase in alpha-fetoprotein, serum alpha-fetoprotein increase. For importance in pathology, it's the most common overlooked component of non-seminomatous germ cell tumor. It's important to find the Yolk Sac component in the orchiectomy specimen. It has a better prognosis if the tumor has more Yolk Sac tumor in stage 1 patients. However, presence of Yolk Sac tumor in advanced stage is associated with poor prognosis. It seems like Yolk Sac tumors has less metastatic potential compared to embryonal carcinoma. However, it's also less sensitive to chemotherapy, and it's also a frequent component of late recurrences. The most type of Yolk Sac, which is endodermal sinus pattern, and has Schiller-Duval bodies, which is the hallmark histology for endodermal sinus pattern of Yolk Sac tumor. But this is a tumor with a wide spectrum of morphology. More than 12 patterns are described. Usually one tumor will have multiple patterns, and the most common type is microcystic pattern, where you see this sort of myxoides stroma and this microcystic spaces. You can have this festooned complex appearing morphology, glandular morphology, and solid morphology in Yolk Sac tumors. Yolk Sac often contain extracellular basement membrane-like material and hyaline globules, which is helpful on H&E diagnosis of these tumors. And again, I would like to stress some unusual appearances in Yolk Sac tumor, which can be very pleomorphic, and where you see a quite ugly appearing pleomorphic multinucleated cells, which could be misdiagnosed as embryonal carcinoma, choriocarcinoma, or even metastatic carcinoma. Next, choriocarcinoma. It's pretty uncommon component of mixed germ cell tumor, and it's very, very rare to see it as a pure form. Almost all associated with elevation of HCG in the serum. Grossly often tumors are necrotic and hemorrhagic, can be pretty small. Inflammation is very common. And with metastatic disease, and important to stress that if it's present as originally as a metastatic disease, it can be diagnosed as a somatic malignancy if we don't pay attention to the patient's age and possibility of germ cell tumor. What's important under the microscope is to find these two cell types, both syncytial trophoblasts and cytotrophoblasts. Again, immunohistochemistry can be helpful to detect those two cell types. The last but not the least on histology is teratoma. These are usually very fun tumors to look at under the microscope because it's a mixture of multiple elements originating from more than one germ cell layer. It's commonly seen as a mixed germ cell tumor, but it could be a pure form too. Foci of teratoma can be non-teratomatous. Again, remember that all of these germ cell tumors are originating from seminoma, and transformation between types are possible at the site of metastasis. So immature components can be seen, and it's not uncommon. However, no data to support it has a prognostic significance. So there is no need to report presence of immature components as a part of teratoma in your report. But it's important to address the significance of patient age because pediatric teratomas behave completely different than post-pubertal teratomas. Post-pubertal teratomas are they're always malignant. Pediatric ones are benign, and there's a reason for that because pediatric ones originate from a benign germ cell tumor compared to post-pubertal one originates from a malignant intratubular germ cell neoplasia. There's 12P amplification in the post-pubertal group where there is no 12P amplification on the pediatric group. Usually, pediatric group does not have cytological atypia, which is common in the post-pubertal group. And the pediatric group is pure, and as we stressed before, post-pubertal ones are mostly a part of mixed germ cell tumor. Two rare entities which are part of post-pubertal teratomas that are benign. These are really rare benign variants of teratoma. They're 12P negative. They have normal DNA component. Dermoid cyst is composed of just a cyst with squamous lining and keratin. Dermoid cysts have additional adnexal units like hair follicles, sebaceous glands, and some other pure components. Significance for the pathologist is you can read this as a part of because they will present as a cystic mass, not a solid mass in testis, and which could cause a partial resection that will come as a frozen section. And all you can see is a keratin-lined cyst under the microscope, and it's important to ask for a complete excision of the lesion and ask some non-lesional tissue so that you can see the presence of or absence of intratubular germ cell neoplasia associated with it. And this is an epidermoid cyst under the microscopy, which shows a squamous line cyst with keratin. The use of immunohistochemistry in germ cell tumor histology. Since histology subtyping is quite critical in the management of germ cell tumors, and morphology can overlap, I think immunohistochemistry has an important role in the diagnosis of germ cell tumors. Especially on challenging diagnostic entities where you're trying to differentiate seminoma from non-seminomatous pure or mixed components of non-seminomatous germ cell tumor. Again, it's very helpful when you're dealing with unusual patterns of seminoma, or if you're trying to estimate the amounts of mixed germ cell tumor components. Again, in a sneaky pattern of intratubular seminoma where only you can see a few nests of seminoma cells in between tubules, it's also very helpful. And if you're trying to confirm presence of intratubular germ cell neoplasia on a case that you need to confirm the presence of it and you have only limited amounts, it's also helpful. The panel that commonly used includes cytokeratin, CD30, for c-KIT, alpha-fetoprotein, beta-HG, and PLAB. Cytokeratin is positive for all germ cell tumors except seminoma. CD30 is positive in a cytoplasmic and membranous fashion in embryonal carcinoma, but not in seminoma and Yolk Sac Tumor. OCT34 is a more recent marker, and it's a nuclear transcription factor expressed in human embryonic stem cells. It's expressed in nuclear fashion in both embryonal carcinoma and seminoma. KIT show a strong staining in seminoma, but not in embryonal carcinoma. Can be focally present in Yolk Sac tumors. Alpha-fetoprotein, it's a specific marker, but has a sort of a patchy staining in Yolk Sac tumors. And beta-HCG is present in syncytial trophoblast and part of the cytotrophoblast in choriocarcinomas. PLAB is also positive in a majority of germ cell tumors. However, it's a less sensitive marker. It looks like the newer markers are more helpful. How is the immunohistochemistry of seminoma? Again, cells are nicely decorated in a membranous fashion with c-kit. OCT3 show nice nuclear positivity in seminoma. Cytokeratin is important because it's native and compared to the other ones. Alpha-fetoprotein CD30 is also negative in seminoma. Again, the morphological similarity of seminoma is same as the immunohistochemical profile. That intertubular germ cell neoplasia is same with seminoma. Activity on cells that are close to the basement membrane, which are large clear cytoplasm, prominent nucleoli are positive with OCT3-4, and same cells, again, intertubular germ cell neoplasia is positive for c-kit. Panel for embryonal carcinoma, cytokeratin positive, CD30 positive, OCT3-4 positive, flap positive. Again, CD30 show nice cytoplasmic membrane positivity, OCT3-4 show nuclear prenuclear positivity. Negative states are also important. Embryonal carcinomas are c-kit negative, alpha-fetoprotein negative, and it's also negative for beta-HCG. Positive for alpha-fetoprotein and cytokeratins, and negative for CD30, OCT3-4, and c-kit. So I just want to shoot some relevant differential diagnostic pictures where immunostains can help. Left seminoma, right solid yolk sac tumors. This could be a potential diagnostic problem on certain cases, which could be resolved easily by immunostains. Again, positive for OCT3-4 and positive for c-kit. Negative for cytokeratins, alpha-fetoprotein, which is different in yolk sac tumor. OCT3-4 negative, c-kit negative, positive cytokeratin, positive alpha-fetoprotein. Typical features, very much like an embryonal carcinoma, nicely resolved on immunostains. OCT3-4 positive on both, so it doesn't really help. C positive in seminoma, c-kit negative in embryonal carcinoma. Again, cytokeratin negative in seminoma, it's the only one that's negative, and positive in embryonal carcinoma. And also, embryonal carcinomas are nicely CD30 positive if you don't have OCT3-4 staining lab. Yolk sac tumor both has solid patterns, and sometimes the atypia in yolk sac tumors can show morphological overlap with embryonal carcinoma. Immunostains are helpful. OCT3-4 positive in embryonal carcinoma, negative in yolk sac tumor. Both are cytokeratin positive. CD30 positive in embryonal carcinoma, negative in yolk sac tumor, and patchy alpha-fetoprotein positivity is usually seen. The other relevant use of immunostains are when you're dealing a mixed germ cell tumor and you can't really estimate the amounts of embryonal carcinoma, which has a prognostic significance. So as you can see, where you have presence of embryonal carcinoma admixed with a myxoid yolk sac tumor. So, and OCT3-4 selectively highlights the component of embryonal carcinoma and negative in the microcystic component of yolk sac tumor. Alpha-fetoprotein, on the other hand, hides the areas of yolk sac tumor, and CD30 again selectively highlights the area of embryonal carcinoma. So it can help for you to estimate the amounts of components in a mixed germ cell tumor. The other entity, which is sort of it's a common thing that can be seen, not one, but it's probably the common tumor that you can see regression is germ cell tumors. It could be partially, or it could be regressed, and it's also called so-called without germ cell tumor. And In most patients will present with retroperitoneal or widespread metastasis. So the clinical scenario will be a patient present with widespread metastasis, and all clinicians can find a small nodule in the testis, which comes as an orchiectomy specimen to you to identify if it's the primary. So it could be very critical and difficult to distinguish a scar caused by non-neoplastic etiology versus a scar resulted from a tumor regression. There's a paper on from Dr. Albright to discuss the features of histological features that are commonly seen in regressed germ cell tumors to help to make this differential diagnosis, and found some features that are reproducible, such as atrophy, microcalcifications, and coarse calcifications. They're not really specific to scars. They can also be caused by scars due to trauma, infectious, or vascular processes. So it's important for a pathologist to really address this issue, to tell the clinicians if orchiectomy is performed on the primary site, if it's a neoplastic scar, because then they don't really have to go and get the other testis for an unnecessary resection. It seems like the most helpful and specific finding on these cases are finding intertubular germ cell neoplasia on the area of the scar. This is also addressed as part of the CP checklist, presence of scar in testicular orchiectomy specimens. You can either identify scar or scar with intertubular germ cell neoplasia, which seems to be present in 50% of the cases. So intertubular component, in situ component is the most specific finding, and it's important for pathologists to be aware of the clinical significance of finding a scar in an orchiectomy specimen. So, moving on to the extent of tumor on microscopic level. What the checklist asks us to do is these parameters. A pathologist should look microscopic extent of the tumor presence in retestis, tissues, epididymis. Do I have a little asterisk associated with those findings? Because these data elements are not part of the TNM, current TNM stitching. However, these elements can be clinically important, but however, there's not enough data, but they are used for patient management, so we have to report them. Other three are tunica vaginalis, which upstage the tumor to PT2, dramatic cord extension, upstage the tumor to PT3 in TNM, and also a rare finding, but scrotal wall extension of the tumor upstage the tumor to PT4. Stress that the first three parameters, retestis, other soft tissue, and epididymis, are all structures located at the hilum of the testis. And the network of channels at the hilum of the testis, which receives all the luminal content from the seminiferous tubule. This hilum has been defined as a site, common site actually, as an extratesticular extension of germ cell tumors. However, there is still no data on the prognostic significance of this area, invasion of this area with tumor. So it's still not addressed as part of the TNM staging. Testicular hilum includes both retestis and soft tissues, which is a connect tissue just beyond retestis, has lots of large vessels associated with it. Microscopic extent, the first one is I'm going to deal with is retestis. Why is it important to report retestis invasion? In stage 1 seminomas, retestis invasion has been found to correlate with higher risk of relapse, and it's also found to correlate with clinical metastasis at the time of presentation. So retestis can demonstrate two patterns of involvement. To call testis invasion, we're required to see presence of tumor cells in between in the spot between the redo-testis ducts. The patch spread, on the other hand, is defined when involvement is exclusively pagetoid, where individual or groups of cells morphologically identical to intertubular germ cell neoplasia is present below or between the epithelial cells of the redo-testis above the basement membrane. And this is a form of an extension of in situ tumor into the redo-testis duct. So CA protocol does not ask to differentiate these patterns of involvement, but as a common sense, you can see this type of invasion addresses direct tumor invasion to the hilum. This type of invasion is only an in situ spread into the redo-testis ducts. So in our synoptic reporting, we make a difference on pattern of redo-testis involvement, and we only report this type of invasion as redo-testis invasion. It's hilar soft tissue invasion. As a micrograph, there is a tumor presence by embryonal carcinoma invading into the redo-testis and also going beyond redo-testis into the hilar soft tissue, which is a connective tissue rich literature, and which not commonly is associated with vascular invasion at the site. So this is identifies a more extensive form of hilar invasion. This is another example of tumor presence, seminoma, extending into the fat present in the hilar soft tissues. Epilation is more uncommon. Again, it's more extensive form of hilar invasion where the tumor invades beyond redo-testis into hilar soft tissues and into the epididymis. Tunicus invasion is part of TNM staging, and the only change on the CP checklist is to stress that vaginalis invasion is positive when the tumor perforates through the epithelium. So let's some images. First of all, where is tunica vaginalis in the testis? Again, this thick fibrous band covers the entire periphery of the testis, which is called tunica albuginea. Tunica vaginalis is this thin mesothelial layer covering the periphery of the testis, which is right on the top of tunica albuginea. So this type of invasion into the tunica albuginea, where it's seminoma on this slide, is quite common. More commonly, you can see seminoma cells right underneath the mesothelium, which is still not perforating it. To call tunica vaginalis invasion, you need to see tumor perforation through mesothelium with all associated fibrin and inflammatory reaction. So for me, it's important to pass this message that the message from this part of the CAP checklist is tunica vaginalis invasion is rare and you'll never see it. So it's still part of TNM staging, but it will make much difference in practical assessment of patients because you never see it. It's less than 1% in our practice. Is forward invasion, which upstages it as pathological stage PT3. No problem when you see a case like that. It's tumor grossly invades everywhere in the specimen, and there's in the spermatic cord, probably including margin, has tumor. The pattern of spermatic cord invasion is more commonly seen than this direct pattern is invasion, found microscopically when you're sampling the mid, proximal, or distal end of the spermatic cord, that you see tumor presence in large vessels. They're not considered, according to the CAP checklist, as direct extension. So you're still considered as a PT2, not a P3 tumor. I want to spend a few slides on this one because it does upstage the tumor. And again, as we discussed, it's important to put clinical stage 1 non-seminomatous germ cell patients into a high risk of relapse. So when a clinician sees presence of vascular invasion on a patient, stage 1 non-seminomatous germ cell tumor patient, they may apply an adjuvant chemotherapy to those patients. So it's critical not to overcall vascular invasion when you're assessing orchiectomy specimens. Vascular invasion is more common on cases where you see predominant embryonal carcinoma component. This is a picture-perfect one, embryonal carcinoma, partly attached, a little bit of a fibrin. So a perfect scenario for presence of vascular invasion. Vascular invasion can be present in larger vessels, and again, as we stressed, this is more common on cases where you see tumor extends to hilar soft tissues. This one, again, must show a conscious effort to avoid overdiagnosis of vascular invasion. This seems to be more of a problem in cases of seminoma. This may cause overtreatment of patients with chemo in the cases non-seminomatous germ cell tumor, and again, overtreatment of radiotherapy for patients with seminoma. What's the difference on this than a true vascular invasion? The cells are quite loose, and usually this is because of the carryover tumor to a larger vascular spaces. There is no attachment with fibrin, and most of the time when you see this type of a change in vessels, when you pay attention, you'll see tumor everywhere. As an artificially present on the surface of the tunica and everywhere. So try not to overcall this one as a real vascular invasion. A picture of a vascular invasion, which I would consider a vascular invasion with seminoma. The difference is more cohesive group of tumor cells attached partly to the wall of the vessel and with associated fibrin. Example of embryonal carcinoma. Again, this could look like a vascular invasion to a large vessel. Usually, it's important to pay attention that what you're actually assessing is a vascular space that are lined by endothelial cells, not a tubule. Most of the time, when it's involving a tubule, it will have more comedonecrosis than a vascular invasion. Again, just another pitfall that can cause upstaging the tumor. Although GP recommendations are pretty clear about what to report, how to report is still left to the pathologist. What we do at our institute to use constant or use of synoptic reporting or on all oncological specimens. So this is the one we use for testicular germ cell tumor. Again, histological type is first. You have to see, say, if it's a pure or a mixed germ cell tumor, and if it's a mixed germ cell tumor, you have to state the percentage of the components. Tumor size, presence of vascular invasion beyond tunica albuginea, again, PT2, rare finding with tunica vaginalis. This is a more common finding, extension to the hilum, however, still considered as PT1 since it's not addressed as TNM. Rhesus invasion present or not present. Epididymous invasion present or not present. Spermatic cord invasion, same. Presence or absence of surgical margin positivity. And in precursor lesion, presence of intertubular germ cell to neoplasia, presence or absent. We tend to bury the pagetoid type of spread into the rhetotestis under intertubular germ cell neoplasia. Necrosis, presence or absence, and again, comments on how non-neoplastic testis present, and example of a complete read on a seminoma, all the features that we've discussed. One more on PT&M stage at the end of your synoptic reporting. You're responsible to report PT You don't have to say anything about PN and PM. You can put X or just not to mention it at all. It will be fine. That's the end of my presentation. I would like to address if any questions are present. Thank you.
Thanks, Asla. That was great. We have, we just have one question that's come in thus far. So if anybody else wants to ask a question, if you can type it fairly quickly, we'd appreciate it. So the first question is from Raymond Mong from Kamloops, British Columbia. If intertubular germ cell neoplasia unclassified is present, is it useful to biopsy the contralateral testis?
It's not in practice, but if it's a unilateral finding versus a bilateral finding, again, it's probably talking about an infertility biopsy, not an association with an orchiectomy done for testicular cancer. Yes, it's a common practice to do that because they are treated differently. Lateral ones can receive an orchiectomy, bilateral ones would be treated by radiation.
Okay, another question that's come in from Karen Burns, Queensway Carleton Hospital, Ottawa. How do you handle a case of germ cell tumor in a testis where previous orchiopexy has been done and where tumor appears to invade tunica albuginea, but there are lots of adhesions on the outer aspect of the testis and you can't tell exactly where the mesothelium of the tunica vaginalis is? Do you err on the side of assigning PT2?
I said tunica vaginalis invasion is quite rare, so if I don't see a definite perforation, which is probably even be visible on microscopy as presence of tumor outside of the testis, P2 through an invasion tunica vaginalis is really rare, so without really seeing that it's present under the microscope, I wouldn't assume that's the case.
Okay, I guess the other aspect of that too is the general rules of TNM is if you're uncertain as to the pathological stage, to err on upper staging,
yes,
using the lower value rather than the upper value.
There are in CAP checklist always a third option after presence and absence as an indeterminate. We can always use that one.
Okay, I have a question, Asla. Any recommendations to improve the current CAP checklist for testis?
Good question. I would probably, the one thing that I found that I think part of my presentation I did mention that the presence of retestis invasion, the pattern should be part of the recommendations, I would believe, because I've seen reports going out as saying, especially cases of seminoma, where pagetoid spread would be part of the diagnostic line as retestis involvement is present. If it's exclusively by pagetoid spread, it's not retestis invasion, and that may cause over-treatment of a seminoma patient by radiation. So please stressing the type of retestis involvement, pattern of retestis involvement is important. Okay.
We do now have, through the Canadian Partnership Against Cancer, we have a group of Canadian representatives to the College of American Pathology Protocol Review Committees, and our national representative for GU is Kirill Tripkov. So anything that you have, you can sort of pass on to Kirill for consideration by the College of American Pathology group on a go-forward basis, which I think is very good.
It could be easy for me.
That's very easy for you. A question in from Dr. Yasa in Brockville General Hospital. Why do you prefer to receive the specimens fresh rather than fixed?
Again, if you rely on your urologist doing the right thing, meaning if they bivalve it correctly and put it in formalin right away, that would be great. That's probably the best scenario, that you receive bivalve testis in formalin. But I think that you always will have the risk of a urologist not paying attention and actually putting it in formalin, not bivalving it, which will lead to autolytic changes in tumor. So it depends on your communication with the group of urologists.
Right. I have another question. Have you had any experience with glycopin 3 for yolk sac tumor?
I haven't. I send my cases to Dr. Albright when I don't have alpha-fetoprotein positivity, but I'm sort of perfect sure it's Yolk Sac Tumor to let him do it for me. But it seems like it's working great for his hands.
Thank you. I don't see any other questions, Asla, so I'll just make a few closing remarks then. On behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to thank Dr. Asla Yilmaz for truly comprehensive, informative, and a very clear presentation today. This is our fourth session in the third series of CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of the evaluation process. Once the next recording of this presentation becomes available, it will be made available widely via links from Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. In order to get these credits for attending or viewing the sessions, you must complete an evaluation form for each session accessed or viewed in its entirety. The link to the web-based survey has been included in the session notices previously distributed. Please note once again that CME certificates for each CAP checklist education session will only be issued for 1 month from the presentation date. Sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be available for 1 month. And please refer to the session notice for the exact deadline dates. Now, the next scheduled session that we have actually is for Dr. Carcinoma in situ of breast, which is March the 28th by Dr. Penny Barnes from Nova Scotia. The one that was previously scheduled for March the 7th, Dr. Bruce Patterson for bone marrow and lymphomas, has been postponed to fall, and we'll be getting back to you with the exact dates at a little bit later date. Thank you very much for attending today, and I'll now bring this session to closure. Thank you.